Blog Talk Radio.
Welcome to today's episode of Inpatient Myeloma Radio, a show that connects patients with myeloma researchers. This is our 33rd show to help you hear about the very latest in research so you can make educated choices about your care. It's also to help you understand why clinical trials are so important. As patients, we help determine the speed at which new discoveries can be found through our participation. Now, if you'd like to receive a weekly email about past and upcoming interviews, you can subscribe to the Inpatient Minute newsletter on the homepage or follow us there on Facebook or Twitter. We also have a new site called myelomacrowd.org. That's the first comprehensive site for myeloma. And just as one item that we have on the site, for newly diagnosed patients, we have a link called I Have Myeloma, Now What?, with some recommended first steps to help you navigate. This is just one of the features of this site. It has a wealth of myeloma information and links to the very best resources out there. Now, many patients have MGUS and smoldering myeloma, and today's show is dedicated to them. But at the same time, to all myeloma patients, and that will become more clear as we go through the show. We are delighted to have with us today Dr. Brendan Weiss of the Abramson Cancer Center at the University of Pennsylvania, who is an expert in the study of MGUS and why and how it progresses to myeloma. So, Dr. Weiss, thank you so much for joining us today.
Thank you for having me, Jenny. I'm pleased to be here.
Well, let me introduce you. Dr. Brendan Weiss is an assistant professor of medicine in the Hematology-Oncology Division of the Abramson Cancer Center of the University of Pennsylvania. Before coming to UPENN in 2011, he spent 13 years as an active duty military physician in the U.S. Army, including 7 years as an attending physician in the Hematology-Oncology Service at Walter Reed Army Medical Center in Washington, D.C., where he was the director of the autologous stem cell transplant program. At the University of Pennsylvania, Dr. Weiss is solely focused on plasma cell disorders, multiple myeloma, amyloidosis, and related conditions. Dr. Weiss is a clinical investigator whose primary research interest is in myeloma precursor conditions, MGUS and smoldering myeloma. Specifically, he's interested in developing new biomarkers to identify a patient's risk of progression to active myeloma and perform intervention studies for patients with myeloma precursor conditions. His work in myeloma and its precursor conditions has been published in leading journals, including Blood, Leukemia, Bone Marrow Transplantation, the American Journal of Hematology, Biology of Blood, Marrow, and Bone Transplantation. So, Dr. Weiss, thank you so much again for joining us today.
Thanks for the kind introduction.
And we have just completed, or ASCO has just wrapped up. So before we jump into MGUS and smoldering, would you like to give us your take on the most important things that came out of ASCO, both for myeloma and, for MGUS and smoldering, and then anything else you'd like to mention in general for myeloma?
Sure. So there were several interesting abstracts presented at ASCO. I think probably the one that was most anticipated because Novartis made a press release about the panobinostat study back in December were the results of the panobinostat in combination with bortezomib and dexamethasone compared to bortezomib and dexamethasone in relapsed myeloma patients. And so this was a phase 3 study looking at panobinostat, which is a drug from a class called histone deacetylase inhibitors, or HDACs, that had been known for some time to be a good combination with bortezomib. But the previous agent that had been tested, vorinostat, was not particularly effective. And panobinostat has some differences in its mechanism of action, so it was felt to perhaps be better in combination with bortezomib than vorinostat. And in fact, there was a, I think, encouraging finding of a nearly 4-month survival benefit when panobinostat is combined with bortezomib and dexamethasone. And I think this will be coming forward to the FDA for approval this year.
And how far away is that by the time they have great results like that?
Well, it all depends on the speed of the FDA process, but it could come within 6 to 12 months.
Okay. I've heard a lot about panobinostat and that class of inhibitors as well. And because you study MGUS and smoldering, was there anything that was very key for you?
I think there were. Yeah, there were probably 2 studies that I think were interesting. One was one of our own studies that we presented, looking at risk factors for progression in smoldering myeloma, and we sought to look at our own population here at Penn to identify new biomarkers for progression, but also to try and confirm biomarkers that had been identified by other groups as associated with a high risk of progression. One of the important things in medicine and science is to see if results can be confirmed in other studies to assess whether they're truly valid. And some of the biomarkers that have been investigated in smoldering myeloma have not been validated in multiple studies. And so, in particular, we were most interested in looking at the group of patients who have an ultra-high risk of progression, as some people have described it. And the threshold for ultra-high risk would be about an 80% risk of progression within 2 years of the diagnosis of smoldering myeloma. And so smoldering myeloma patients, by definition, are asymptomatic, but if they have such an ultra-high risk, it may be useful to consider treating those patients. And so in our study, we were able to confirm what had been previously reported by the Mayo Clinic and the Greek myeloma group, that patients with smoldering myeloma who have greater than 60% bone marrow plasma cells do have a very high risk of getting myeloma within 2 years. In our study, 100% of patients develop myeloma.
Wow. Well, that seems pretty consistent and reliable.
Yes. However, we did have some discrepancy with the Mayo and Greek groups that we're trying to look into in a little more detail. One of the other tests that patients with smoldering myeloma and myeloma get is the serum-free light chain assay. And that can be a very helpful assay for a lot of reasons in myeloma. And the Mayo group and the Greek group has previously identified that patients who have a very widely skewed serum-free light chain ratio of greater than 100 have roughly a 75-ish% risk of developing myeloma within 2 years. However, our study was a little bit lower than that, and we only showed roughly a 50-ish% risk in 2 years. So I think we need to go back and look at our own data in a little more detail to see why there's some difference before we can say with certainty that this biomarker is truly a strong biomarker to identify ultra-high-risk myeloma patients. Ultra-high-risk smoldering myeloma patients.
And what would be one of the factors why there would be a data difference? I'm just curious.
Yeah, I think that's a really good question. I think one possibility, and we're in the process of going back and reanalyzing it, is our initial analysis excluded patients with what is called light chain only smoldering myeloma. And we did that intentionally because we wanted to include patients in our analysis that were most similar to the original Mayo Clinic studies. However, the Greek group and more recently the Mayo group did include a small group of patients with light chain only smoldering myeloma. And so we're going to go back and analyze the data, including those patients. And another important factor that has been somewhat understudied, and we're not sure yet of the relevance of this, is that in our population in Philadelphia, we have a much more ethnically diverse population than at the Mayo Clinic or in the Greek study group, and about 20% of our patients are African American. Mm-hmm. And previous studies that I have done had shown a suggestion that in particular serum-free light chains might differ in patients who are of African American background, and reasons for that are unclear. And so this is an area that definitely needs some more study if we're going to use serum-free light chains as a biomarker for all patients.
And I think we're going to ask some questions about race because you've done specific studies on that. So we'll come back to that, I think.
Okay.
And is there anything else at ASCO you wanted to share?
Yeah, I'd like to share one other very interesting study because it also is an area of interest for us, and it has to do with identifying the impact of metformin, which is a drug that is used for diabetes. And its impact on the transformation of MGUS to multiple myeloma. There has been many studies on the impact of metformin in diabetics and cancer, development of cancer and cancer outcomes, but these studies actually did not include patients with blood cancers. And so the reasons for this there are probably many reasons that metformin may have anti-cancer effects. In those studies of diabetics I mentioned before, metformin can reduce the chance of getting cancer by about a third, which is a pretty strong signal.
Yeah, definitely.
And the reasons for that could be related to changes in insulin sensitivity, because insulin is a known growth factor for cancers, and in particular myeloma. But metformin may have other actions on specific cancer signaling pathways, such as the mTOR pathway, as an example. But so this group from Washington University in St. Louis, in collaboration with investigators from the St. Louis VA Medical Center, actually evaluated over 2,000 MGUS patients with diabetes in the VA system. And they did show that there was roughly a 40% reduction in development of myeloma.
That's really stunning.
In patient, yeah. So I think this is very interesting preliminary data.
I have a question about that because with patients being on dexamethasone, which does affect your blood sugar levels pretty significantly and can give you diabetes, ultimately, if in some patients it can. I'm surprised that that metformin, I haven't talked to anybody yet, I guess, about metformin and the impact it has in progressed myeloma. But you're saying this has even been tested in MGUS. I didn't know that.
Yes. So we're in the process of actually looking at all those questions through our own database here at Penn, as well as through other pharmacoepidemiology databases available. Because, as I said earlier, the effect of metformin has predominantly been studied in solid tumors, but not in any blood cancers and not in myeloma specifically. But the reality is, metformin is so commonly used, and among the diabetes is common, and so it has been combined with chemotherapy. One might say unwittingly, in the sense that the patients continue on their anti-diabetic medications throughout their chemotherapy regimens. And in general, assuming they don't develop a contraindication to continuing the metformin during their therapy, which in myeloma the most common reason for that would be development of kidney problems, many of these patients were continued on their metformin, and so I think we have some possibility of answering this question regarding metformin and its impact on both patients who have myeloma precursor conditions, as this group from WashU did, but also in patients with active myeloma.
And are you able to go back to your the data that you already have and do any retrospective studies to kind of save time? So we are planning on looking at our own database here at Penn of patients who have both active myeloma and smoldering myeloma who were exposed to metformin or not. Okay, well that will be very interesting to see the results from that.
Right, but I should say right now, when we have data like this from epidemiologic studies, it doesn't mean that patients should be rushing out to start on metformin for the purpose of preventing myeloma.
Mm-hmm. I think it sounds like you need more data before you can come to that conclusion.
Correct.
Well, let's go back and first understand how you began to study MGUS primarily and smoldering myeloma. What intrigued you about focusing on that aspect of myeloma?
So that's a very interesting question, and some things in life just sort of happen, I think, by serendipity. It was back in 2001. I had moved to Washington, D.C. to start my fellowship in hematology oncology, and at the time, I knew I was interested in the hematology side of things, but I wasn't really sure if I wanted to go into malignant hematology and study blood cancers, or actually do benign hematology and study thrombosis. So I was quite undifferentiated when I started my fellowship training, and as it happens, I met Michael Keel, who you've had on your program previously from the NCI, and I met him playing squash, actually, not in a more academic setting. And sort of one thing led to another. As I progressed through my fellowship, I became more and more clinically interested in myeloma. And Michael Keel is, as you know, is a scientist who's been studying myeloma for quite some time.
Mm-hmm.
And so he became a mentor of mine, and we had many meetings both on and off the squash court, and he taught me a lot about the molecular pathogenesis of myeloma. And, one day we discussed the fact that this very fundamental question about the pathogenesis of myeloma, this question of whether myeloma is always preceded by a precancerous state, a premalignant state, had really never been answered. Even though it seems simple, but actually is quite difficult to answer, because by definition, patients with myeloma precursor conditions don't have any symptoms, so patients aren't being screened for this. However, I was able to take advantage of a resource that is present in the Department of Defense, which is a serum repository that exists for now close to 25 years. Active duty service members have blood taken every other year for force testing for HIV, and the serum is leftover serum is stored.
That's a great resource.
Yeah. So now it's obviously not collected in the context of a prospective clinical trial. So, occasionally a service member might miss a collection, or, of course, when the repository began, it was being rolled out throughout the military. So, over time there are more and more samples. And so with that resource available to us, we designed a study to look at the patients with myeloma who were evaluated and treated with an autologous transplant at Walter Reed, and to go back retrospectively from the time prior to their diagnosis, and to pull their serum and test it for the presence of a monoclonal protein.
Well, that's a fantastic resource to be able to go backwards like that. I think that's one of the downsides, is that people aren't tested right up front, and then it's hard to know if you have MGUS or not.
True. So in our study, we were able to show that essentially all patients who have myeloma, who develop myeloma, have a pre-existing monoclonal protein that's detectable many years before they actually develop myeloma.
And in general, I've heard different percentages about what percent of people in the United States in general probably have an MGUS or do have an MGUS, and then many probably don't know that they do.
Right. The vast majority probably don't know, since we don't have screening of the population.
And I've heard percentages like 1% to 2%. Is that correct?
So it really depends on age and ethnicity. And the studies from the Mayo Clinic focused on Olmsted County, and then more recently the NHANES study was more geographically and ethnically diverse. But I would say, as a rule of thumb, roughly 4 to 5% of people over the age of 50, have a monoclonal protein. But the frequency of a monoclonal protein will change depending on age and ethnicity. So aging is a risk factor for developing a monoclonal protein. So people in their 70s and 80s probably have a 10 to 20% prevalence of a monoclonal protein, whereas patients in their 40s or 50s are down in the 1 to 2%. And for African Americans, those numbers, could be about double what I quote. So it depends on all those factors. So it is reasonably common condition.
And in talking to Dr. Keel, he was saying that there are a lot of people that don't progress to myeloma. So maybe we want to talk about your general approach to evaluating somebody with MGUS, and then how you are working to stratify patients into the various risk groups.
Yeah, I think that's a great question. And I think this is where seeing a hematologist who really thinks about monoclonal gammopathies is important. Most clinicians tend to focus heavily on, is myeloma present or not? But the reality is the presence of a monoclonal gammopathy is really a biomarker for possibly other conditions that also need to be excluded. And so generally, when I'm evaluating a monoclonal gammopathy and counseling patients on what their monoclonal gammopathy means, I usually tell them that there are two broad categories that we need to think about. One is there evidence of myeloma, or is there evidence of a protein-mediated disease? That is that monoclonal protein in the blood actually causing a disease? And so those are things like light chain amyloidosis or monoclonal gammopathy of renal significance or monoclonal gammopathies associated with a neuropathy. Those conditions are very uncommon, but they're important to identify. And if those are not identified, if the patient doesn't have any obvious evidence of myeloma with Crab features, and they have no evidence of a renal dysfunction, as in a monoclonal gammopathy of renal significance, or any evidence of light chain amyloidosis, such as heart failure or protein in the urine, unexplained weight loss, things like that, then the patient would be classified as having MGUS. And then the real question at that point is how much further of an evaluation is needed? Do the patients all need to have a bone marrow biopsy, X-rays, and now there's much talk about doing other advanced imaging. And that's really on a case-by-case basis, usually based on the patient's individual risk factors.
Well, that was one of the emailed-in questions from one of the patients, and he said, it was Gerald, and he said, would you recommend that every MGUS patient have a bone marrow biopsy?
So actually, that's a great question. The International Myeloma Working Group does have guidelines for the evaluation of monoclonal gammopathies. And their recommendation is that patients should have a bone marrow biopsy if they have any high-risk features. And those high-risk features are the ones that have been laid out by the Mayo Clinic in their studies of MGUS progression, and those include a monoclonal protein concentration greater than 1.5 grams, a protein that is not an IgG type, okay, or an abnormal serum-free light chain ratio. So those patients, it is recommended that they have a bone marrow biopsy. Now, of course, I would say it's appropriate for any patient to have a bone marrow biopsy who have a monoclonal gammopathy who want more information. Because one thing that's missing if you don't do a bone marrow biopsy is the ability to stratify between smoldering myeloma and MGUS. Because the key criteria there is having a bone marrow plasma cell infiltration of greater than 10%.
And you only can identify that through the bone marrow biopsy. Well, I would think that's critical then.
Yeah, I mean, obviously we can get additional information from the bone marrow biopsy, and also if the patient is seen in the context of a research study, the bone marrow biopsy can often be helpful, is critical to distinguish between MGUS and smoldering, but also to obtain plasma cells for future study.
And would it be valuable, because we've talked a lot about on this series about genetic testing, would it also be valuable to see if there are any do you see translocations at that stage or later on, only later on?
Right, and so that is also a great question, and this is one of the things that Dr. Keel has studied for a while and has been very influential, and that is to say that the molecular genomic features that are seen in patients with active myeloma, whether it is a translocation or a deletion of a specific chromosome. These can be found in patients with smoldering myeloma and with MGUS. And the frequencies can be somewhat different, and it's also not clear whether having certain translocations or deletions changes the risk of progression to active myeloma in MGUS and smoldering. And in fact, the recent studies, both from the Mayo Clinic and from the German group, have shown that including various abnormalities found on fish testing, so the fish testing enables us to detect translocations, hasn't allowed us to refine the risk of progression in smoldering myeloma. So I think right now it's useful to have that information, but it's not going to change our management of the patients.
Well, just in talking to others, and maybe this is just my personal preference, is that the more you know up front, the more choices you can make later on. And so I think that the deeper information that you have, just the more well-prepared you are to make the choices that you need to about your treatment and your care.
Yes, I mean, I think I kind of agree with you from the standpoint is it's good to have as much information as you can. It's really hard, I think, from the physician side to know what's important for any individual patient to help them make decisions about their care. And so I think if in discussing with an individual patient, they really feel that having as much information as possible will help them make decisions, I'm in favor of them having a bone marrow biopsy.
Well, I would agree. And I think some of the concern is that if you start getting treatment at any smoldering stage and then you don't get that information, then some of that information can be lost to you. So,
well, yeah, I would say, treatment of smoldering myeloma does still remain an area of research. And then in patients who do get treatment of smoldering myeloma, they should be in a clinical trial that obtains that information. I totally agree with you.
Mm-hmm. And then can you share what you are discussing about imaging tests to detect early MGUS or smoldering myeloma? How has that progressed?
Well, I think imaging in myeloma, both for active myeloma and the precursor conditions, is really challenging because myeloma is a disease that affects the entire skeleton, and so you have to image a large part of the body. The current standard is to use a skeletal survey, which is simply a plain X-ray of all the bones in the body and the central skeleton, basically, and the appendicular skeleton, so the long bones. And that test is generally, in patients with active myeloma, is really only positive about 80% of the time to detect bone lesions. And so you can imagine in a patient with smoldering myeloma or MGUS, those types of tests are going to be somewhat less sensitive, even if there is bone disease. And so there's been a lot of investigation into using more sensitive techniques for detecting bone disease, so that's osteolytic bone lesions, with modalities such as low-dose CAT scan, which can image the whole body very quickly and is more sensitive than a skeletal survey for detecting those bone lesions. And then MRI scanning has been has been investigated to look for focal bone marrow activity of myeloma, and that also seems to be very, very sensitive, even in smoldering myeloma. PET scanning has been looked at as well. That's a technique where radioactive glucose is injected into the patient and the whole body is imaged along with a low-dose CAT scan. And that test, I would say, in smoldering myeloma has not been as helpful as MRI scanning.
So
these
MRI,
tests are... Go ahead.
Well, in the MRI scanning, I've heard, I think it was the UK group, talk about the whole body imaging. Is that progressing here in the States too? That's part of it was a whole body MRI from what I thought.
Yes, you're correct. And so at our own center, we do not do MRIs routinely for patients with smoldering myeloma. It's very challenging to get insurance approval for that. And also, most centers, including ours, are not routinely doing whole body. We're doing spine and pelvis, which does cover a large area of possible myeloma activity in the bone marrow, obviously, but it does miss part of the body. And so I think in the United States, and others of my colleagues may disagree, but it's quite difficult to use MRI, whole body MRI, routinely.
And maybe as the costs come down, I think they were trying to do it in a different way, or
yes,
maybe as costs come down, it wouldn't be such a big issue.
Exactly.
Well, are there any other? There were some prognostic indicators that I read about in some of your work, and I don't know what they are, so you'll have to explain them. So
sure.
I saw mentioned CMCCs, microRNAs, MIR16 and MIR25, and I hope you can explain those in patient-friendly language.
Sure. So I'll focus first on the CMMCs. I think it'll be the most easily understood. Currently, we're doing a study here at Penn where patients with MGUS and smoldering myeloma can come and have an evaluation that includes collection of peripheral blood, and for those who need a bone marrow biopsy as well, and the rest of a standard evaluation. And the primary goal of the study is to evaluate the performance of a new test called circulating multiple myeloma cells. This is not a new idea per se. Other groups have looked at the ability to detect and count the amount of myeloma cells that are circulating in the blood. And they've used different techniques. However, those techniques either are very labor-intensive or have not been developed for use at other centers, so they're not widely available. The advantage of this technology is that it is an extension of a technology that was developed years ago that is called cell search, and it was originally developed for detection of very rare cells in the blood in patients with other kinds of cancers, so in breast cancer, colon cancer, prostate cancer as an example. In those diseases, there are very few circulating cells generally compared to blood cancers, so they had to develop a technique to enrich the sample of the possible circulating tumor cell and then classify them. So and the other advantage of the technology, in addition to be able to find rare cells, is it is mostly an automated process. So there's only a modest amount of actual human operator required for each individual sample, so many samples can be done with less work, and the turnaround time is much quicker for the results. So because of that, this could be easily used in the clinical lab. And one other advantage I should bring up is that when the blood is drawn from the patient, it's stable for up to 4 days. And so the other ways of looking at circulating myeloma cells require that the sample be processed the same day. So it has a lot of possible advantages for both the ability to detect rare cells, but also in pragmatic terms, it can be used pretty easily in the clinic.
And why is the number of cells important? Can you just give us perspective?
Yes. So one of the when I speak to patients about myeloma, I always explain that the reason the disease is called multiple myeloma is that term means that it's a cancer of many bone marrow tumors. And so if one were to look at a skeletal survey of a myeloma patient and see all those different lesions, those are different deposits of myeloma cells in the skeleton. And so there must be a way for the myeloma cells to go from one part of the skeleton to another and have these deposits. And so it's been known for many years that using different techniques, these cells can be found floating in the blood. And in patients with more advanced myeloma, there's generally more cells in the blood than in patients with less advanced myeloma. And also in some studies that have been done at the Mayo Clinic using their own technology in both MGUS and smoldering, the amount of circulating cells in the blood seems to result in a shorter time to development of myeloma.
All right.
And so detecting the circulating myeloma cells seems to capture another aspect of the biology of the myeloma precursor conditions, namely the active spreading of the myeloma cells in the blood to other sites of the skeleton, which is something that is not directly captured by our other tests.
Okay, that makes sense. Are there any other indicators that you look at, or
in our ongoing study?
Yes, or in your clinical practice? Mm-hmm.
Well, we use all the standard indicators that are recommended by the International Myeloma Working Group. One of the areas that's become somewhat of greater interest is in patients with MGUS. We have to be worried about the concern of myeloma in the future, but we also have to be concerned about the possible development of light chain amyloidosis, which is a related disorder whereby the protein, the monoclonal protein itself, is causing problems for the patient and not tumor growth of the plasma of the myeloma cells. And so for those patients, early detection of organ problems could be potentially useful. So some of us in the field have recommended checking blood tests of heart problems, heart strain, periodically in patients with monoclonal gammopathies to see if we can pick up the very rare patient who is developing light chain amyloidosis. And so that's something that I do consider in some patients. And then I think periodically patients should also have their urine evaluated for protein. because in some patients, urine protein is a more significant component of their myeloma precursor condition, but also could be a sign of protein-mediated diseases such as amyloidosis or a monoclonal gammopathy of renal significance.
Okay, well, it seems like the testing is very critical, so you know which direction to head.
Yes. Yeah, and of course, it's always important to have a clinical history and to make patients aware of symptoms that they should report to their doctor. We recommend that MGUS patients and smoldering patients come back to see us about every year, every 6 months, depending on the individual factors. But certainly, if there are things that patients are concerned about that could be worrisome for myeloma, we would like to hear about that.
Mm-hmm. All right, now that we've talked about diagnostics, I don't want to take up all the time without talking about probably the most important question for MGUS patients, which is what can you do or what are you working on to prevent MGUS from progressing to active myeloma? And I know you've done some work studying the bone marrow angiogenic environment. So can you talk about that for a bit?
So, I think one of the great challenges in MGUS, in contrast to smoldering myeloma, is that the vast majority of patients with MGUS, so 90% or so, should be reassured that they're not going to develop myeloma or some related condition in their lifetime. And so that leaves a small group of patients who are at risk of developing myeloma. And the real question is, can we do anything for those patients to reduce their risk? And could we even perform a study given the low risk of progression in those patients over a long period of time? And so I think it's really challenging to do a study in patients with MGUS of a specific intervention for, let's just say metformin as an example, because the time frame would be several decades. And it would be very difficult. So the question you're really asking is, what would I tell a patient to do now if they have MGUS? And although we don't really have clear studies that have looked at what personal interventions one could make to reduce the risk of myeloma, there are sensible recommendations for lifestyle and diet that can lead to healthier life, including reduction in cancer risk. And actually at ASCO, Dr. Kolditz, who was one of the investigators on the metformin project I mentioned earlier, has a very detailed website talking about general things one can do for cancer prevention. And I can send you that link later if you want to put it up on your website.
That'd be great.
That I think makes sense for patients to follow. And they're the things that you hear about, on the news periodically about exercise and following a plant-based diet, maintaining a healthy weight, avoidance of tobacco, and minimization of alcohol. All these types of things make sense. And even if we don't have a clinical trial that says it definitely will prevent myeloma, I think it will have great benefits for patients, for their general health.
And I think we all want to look at preventive strategies. Even patients who are in remission in that kind of status, so whether they've had active myeloma or not.
Could you rephrase that question again?
Oh, no. I think we all are looking for preventive strategies, even active myeloma patients that are now in remission. They want to extend that time frame as much as possible, and so do smoldering myeloma patients. Just we're all looking for those kinds of strategies.
Yes, I think that's true, and that's one of the most common questions I get in clinic.
Can you talk a little bit about the bone marrow angiogenic environment? Because we've done other interviews, for example, with Dr. Rajay, who studies the bone marrow environment, and how different signaling pathways can cause cell growth. And it sounded like from Dr. Keel there were several different steps of triggers that triggered. So can you share what you've found about the bone marrow environment and how it impacts myeloma growth?
Well, the only work that I did is I participated in some imaging studies that, while I was an adjunct investigator at the NCI, that looked at a correlate of angiogenesis based on a special MRI type test. And then I know that several groups over the years in Boston and at the Mayo have looked at angiogenesis, and Dr. Raj Kumar and Dr. Kumar have shown that there appears to be some type of so-called angiogenic switch that occurs during the development of myeloma at some point during the transition of MGUS to myeloma, if you will. And I think the reasons for the angiogenic switch, I think, are still somewhat unclear, but it is something that has been seen in other cancers. As cancers need to establish fertile ground for their growth, one of the things they need is nutrients. And so forming new blood vessels can help with that process. But these new blood vessels are often not very healthy blood vessels, and may not be as efficient as normal blood vessels in supplying the tumor with everything they need. And in fact, it could be that's part of it, is that these new blood vessels are allowing the tumor to have an environment that's better for their growth by possibly being malfunctioning. And sort of protect. One of the thoughts is that angiogenesis, in addition to other things that are in the microenvironment of the tumor, actually are protecting the tumor from the body's defense mechanisms against the tumor growth. And that's an area that's obviously actively being investigated, because if we can alter the environment of the tumor, we might be able to allow our body's immune system, for instance, to more effectively target the tumor, or by targeting the environment, we might be able to increase the efficacy of our current drugs.
Okay, that makes a lot of sense. Now, I know we have caller questions, and I want to get to those, but I want to also ask you about studies that you are working on right now, and studies that you have planned. So, is there a specific study that you'd like to talk about?
Well, I would obviously like to reiterate that we do have an observational study for patients with MGUS and smoldering myeloma to develop these new biomarkers, including circulating myeloma cells and others. We are also participating in a study that involves treatment of patients with high-risk smoldering myeloma. It's a monoclonal antibody called siltuximab. And that's an international study that is investigating this agent which targets interleukin-6, which is a cytokine that is a known growth factor for myeloma. And so for patients with MGUS smoldering and very high-risk smoldering, we do have studies for all those patients.
How do you target interleukin-6? I mean, how do you test for it?
Well, that's a great question. Interleukin-6 can be difficult to assay in the blood, and so it's done by really some cytokine profiling methods, but also as a surrogate, we can use a common test called CRP, C-reactive protein, which can give us a rough estimate of interleukin-6 levels in the blood.
Well, I think the variety of tests is really interesting. The patients need to be really on top of things to know what tests to ask for.
Yes.
So that's why we always ask for tests. Well, I would like to open it up. I have so many other questions for you, and I don't know where the time goes, but I would like to open it up for caller questions so people have an opportunity to ask their questions while you're online. So
Great.
If you'd like to ask a question of Dr. Weiss, you can call 347-637-2631 and press 1 on your keypad, and we have some emailed in questions as well. So we'll start with our first caller at 983-6757. Okay.
Hi, Dr. Weiss. How are you? This is Dana Holmes. Thanks so much for doing this show today. Hey, thanks so much for doing the show and sharing all this great information. I have a couple of questions. First, concerning your ASCO poster, which you presented the results from your retrospective study comparing the ultra-high-risk smoldering progression models, which support the Mayo and the Greek group models in relation to plasma cell burden. How does your prospective observational study differentiate an evolving versus a non-evolving state for those who are not ultra-high risk? Which of the biomarkers that you're utilizing appear to have the most promise to actually differentiate this?
Oh, you mean in my ongoing study?
Correct.
Oh, okay. Well, it's nice to hear your voice. I've only met you via Twitter, I guess, previously.
Yes.
Anyways, so the answer to your question is we don't know yet because we have not fully enrolled the study and we don't have enough follow-up time yet. And so it's really hard for us to know any of the new tests that we are using are going to pan out. We just don't know.
So you need new study of participants.
We need participants, yes. I mean, that's the challenge of clinical research, is that, 97% of patients who have cancer in this country are not participating in clinical research. And so, we would love to come up with strategies to increase interest and participation in clinical trials.
Do you need both MGUS and smolderers for your trial?
Yes. Yes.
You do? Okay, because, we do have those Facebook groups where everybody follows all of this, and Jenny's been a tremendous support for us and provides this information. So it's good to kind of get that word out by these interviews. Maybe some of the smolderers and MGUS folks who live near UPENN might consider coming on up and participating.
Yeah, I think that would be great. I think, some patients, I didn't know there was a Facebook group until one of my patients mentioned it. So, we're always interested in evaluating patients for our studies.
Which tests would a participant undergo at the beginning of your study? Would all of us need a new or current bone marrow biopsy? Do you utilize the gene expression profiling? Which one do you use? Do you use the FISH probes? Which one?
Right. So for our particular study, patients need a current bone marrow biopsy. And what that means is they have to have one that includes a FISH panel. We do not do gene expression profiling in the study. I shouldn't say that. We are not. We may be doing that later on, but we're not doing that prospectively. And so patients, if they had a bone marrow biopsy with their local physician 2 months ago, they are not required to have another bone marrow biopsy.
Okay.
But they will be getting blood tests, peripheral blood tests that for research.
And that is what, initially and then every 6 months?
Correct.
Okay, and do you also run flow cytometry on the bone marrow?
If they come to us to do it, yes.
And do you utilize the Pamitha Group's
yes.
model, the flow?
Mm-hmm.
And
yes.
which results do you actually share with the participants?
So we do not share any research tests with the patients.
Mm-hmm.
And that includes, we have not been sharing the pathema with the patients. We haven't really been asked by any of the patients about it, and I think I have some concerns about the flow cytometry. I think it's very interesting, but again, has really been only done in one center, and another center is evaluating it right now. So I think it's still investigational.
Okay.
And so I would feel somewhat less comfortable letting patients know.
Okay. From past interviews, we've come to understand that the so-called first hit, which causes an MGUS clone and the primary abnormalities of trisomies and the IGH rearrangements, can perhaps be environmentally related or even a chronic stimulation of the immune system as a potential phenomenon, chronic infections, inflammatory autoimmune conditions. Yet the second hit, which drives the proliferation, is as random as a lottery. So as a patient, how do we put the predictive risk models into the right perspective?
That's a great question. My bias is that the majority of our current models, our current biomarkers in MGUS and smoldering, focus on surrogates of the tumor itself, tumor growth or tumor mass, if you will. So those are things like the M protein, the bone marrow plasma cells, the serum free light chain. But we also have to consider that myeloma is doing other things to patients. It's, destroying their bones, it's injuring their kidneys, it's having other effects on the immune system. And that's why, for instance, in our study that we presented at ASCO, we were interested to find that a low albumin level seemed to be a strong predictor of progression to active myeloma. And albumin is a very nonspecific, but it is also a biomarker for the staging system for myeloma. And so albumin might be telling us something beyond just the tumor, telling us about what's going on with the patient more globally from a health perspective. And so this gets me to the point that one of the other things we will be researching in our study is to do a broad proteomic profile, so looking at levels of over 1,000 proteins in the blood to see if any of these other proteins, which are participating in other biologic processes, so angiogenesis perhaps, kidney injury or kidney's response to injury, inflammation, as you mentioned before. There's a lot of different proteins participating in inflammation. If whether detection of any of these abnormalities could tell us something more about tumor progression and perhaps put things into perspective of, what's happening with the first hit and then the random second hit. Perhaps, I don't know.
So we're still a long way off from having real definitive kind of concrete answers
to what causes the second hit.
Just who would actually be evolving versus non-evolving.
Well, I think we have some things that are helpful. I think the bone marrow plasma cells of 60%, as you mentioned, I think is helpful. I think that patients who have, MRI lesions, I think are probably at high risk. I think the serum free light chain needs a little more work and may be a strong biomarker, but I still think we need to look more carefully there as a biomarker in isolation.
Great. Well, thank you for what you're doing, because we really do live in that gray zone, and it's very unsettling.
Living with uncertainty is very difficult.
Oh, it is. It's not an easy day-to-day kind of thing. Is your group considering, because I know your UPENN has been known to lead the way with immunotherapies and things of that nature. Is your group considering any strategies or trials to delay progression for smolderers who are not ultra-high risk, which includes immunotherapy coupled with novel anti-myeloma agents? Because on another interview, Dr. Richardson spoke to coupling the Oncopep vaccine, the PVX410, with short-term Revlimid use, and Dr. Orlowski also spoke to similar Rev coupling with perhaps an anti-PD-1 antibody. Is your group looking at these types of strategies as well?
So at present, we are not exploring those types of vaccine-based strategies. Now, we are open to exploring them. However, our efforts right now on an immunotherapy standpoint are devoted towards developing CAR T cells for active relapsed myeloma. And that is, at present, that is not a technology that would be safe to give smoldering patients.
Okay. Well, great.
But, I mean, in 15 or 20 years, I can't tell you if that's a technology that could be refined and be safe. It's hard for me to know.
Right.
But I do think the vaccine ideas are interesting.
Okay. Well, Dr. Weiss, thank you. Thank you for allowing me to ask you all these questions, and thank you for all of your support for the smoldering and the MGUS communities. We really do appreciate it.
Oh, thank you. Thank you for your interest.
It was great talking to you. Okay, take care.
Okay, thank you so much for your question. And I have a couple more emailed questions that I'll just ask very quickly because I know we're over time. First is by Gerald, and he says, do you recommend that all MGUS patients be seen by a myeloma specialist?
Well, I'm obviously biased, but I would say at least once. And I think others of us in the field have said the same thing about a myeloma patient. I mean, not everyone can easily get to a myeloma center. And so it's obviously a big commitment in time and resources, but I do think it's very helpful. Our community oncologists do amazing work, and they are really, most of them, I would say, are overwhelmed with patient care. But myeloma is 1% of cancers, and so it's hard for them to stay up to date on every little thing in MGUS and smoldering myeloma. So we're really here as a resource for the community oncologists as well as the patients. If they're interested in learning more about their MGUS and smoldering myeloma, I would absolutely encourage them to seek out a center that has expertise. And Jenny, as you told me before the interview began, that you are developing a resource on your website to list all these centers, I think is great.
Yeah, I think it's crazy that people can't go online right now and find a single place where they can find a myeloma expert, because as a patient, I really advocate going to see a specialist because they just look at it in a lot more detail. And it's different treating hundreds of patients versus 5 or 10 MGUS or myeloma patients or smoldering or myeloma patients in your clinic. So I'm a very strong advocate that no matter what, you have to go see a specialist. The last question, then I have an ending question, is from David, and he asks, can you explain monoclonal gammopathy of renal significance?
Yes. So this is a complicated term that is meant to capture the various forms of kidney problems that can occur in the setting of monoclonal proteins. And there are many different subtypes to the MGRS, but the common theme among them is that the patients have a plasma cell or B cell clone in their body that is producing a monoclonal protein that, for reasons that are not fully understood, have the propensity to injure the kidney. And this was a term newly described by Dr. Lung and Dr. Kyle from the Mayo Clinic to try and make sense of this group of disorders, and also to drive home the point that these disorders should be treated in a way that is similar to myeloma or amyloidosis, in that chemotherapy should be given to eliminate the production of this bad-acting protein, if you will. And so to that end, the International Kidney and Monoclonal Gammopathy Research Group has been meeting periodically to discuss these disorders, and we published a paper in Blood about our opinion on how to treat them, knowing full well that there have not been a lot of prospective studies of treatment.
Well, I like the fact that everyone's getting divided into buckets that then helps them get the proper treatment for them personally. I think it's very, very helpful and that's why we're asking so many questions about the testing and where do I fit and where do I stand and what should I do with that information. And the last question I have is, what does clinical trial participation mean to you, or what could you do with your research if you had a larger number of patients participating?
Well, that's a big question, obviously, and the short answer is that with more patients participating, we can complete the studies more quickly, and we can accelerate advances in cancer care and understanding mechanisms of cancer, therapies for cancer, and that's how ultimately all patients benefit, is through the work of investigators and the bravery of patients to participate in these studies. And myeloma has been really fortunate to have such major advances over the last 15 years or so, with so many new drugs, and in fact new classes of drugs, and it proves that if we can get investigators and patients together, we can make advances.
Well, we will follow up to help with you to find a way to write a post about your observational study, because I look at observational studies and I think they're so easy to join. They're just
I wish it were true.
Well, we'll help spread the word. Well, we thank you for going over time, and we're so thankful for what you're doing for myeloma patients. We hope you keep up the great work, and we're just very grateful for your dedication to the field and to patients themselves.
Thank you very much. It was a real pleasure, and thank you for what you're doing to spread the word to patients.
All right. Well, thank you again. And thank you for listening to another episode of Innovation in Myeloma. Join us next week for our next M-Patient Radio interview as we learn more about how we as patients can help drive a cure for myeloma by joining clinical trials.
It is Ryan here, and I have a question for you. What do you do when you win? Like, are you a fist pumper, a woohooer, a hand clapper, a high fiver? I kind of like the high five, but if you want to hone in on those winning moves, check out Chumba Casino. At ChumbaCasino.com, choose from hundreds of social casino-style games for your chance to redeem serious cash prizes. There are new game releases weekly, plus free daily bonuses. So don't wait. Start having the most fun ever at ChumbaCasino.com.
No purchase necessary. VGW Group. Void where prohibited by law. See terms and conditions. 18+.